scoring, the component of this very simple is hemoglobin. So this side, which is very commonly used, it has some benefit of that, I'm not going in detail. That score varies between 0 to 100. So if scoring, how you have to calculate? Nowadays everyone is having that. Go to the side, put the figures, you will get this is nowadays no our times when you have to calculate. So this is PG, you get the calculated with the side, you can get this. It's a 1 minute job. So if it is between 0 to 25, that is the low risk. So you can decide to give the double antiplatelet for the prescribed duration of, as we follow this type of standard use. And if it's less than, more than 25, then risk of bleeding is very high. Be careful. Use the shorter period as possible, right? And there is other method as well there. I'm not going on that. These are the list of the bleeding assessment tests are there. So many, but we don't use all in practice. It should be only precise and the DFPT is the second. This is determination. All you must have heard who is the surgeon that has bleed score. Has bleed score basically is not antiplatelet assessment. It's assessment for the anticoagulation. It was used previously when patient was in warfarin. We are not using the oral anticoagulant therapy. So this is also the application of that. H stand for the hypertension, A for the abnormal liver function, S for the stroke, B for the bleeding, S for Levi INR, E for elderly more than 65 years, and next is the drug or alcohol. So we give the awarded the form. If score is more than 3, the risk of bleeding is very, very high. So these are the way we assess the patient's bleeding risk and thrombotic risk, and then guideline is telling that to decide. This is the if patient has this. Another possibility, suppose patient bleeded GI, what to be done in such case? Just I am presenting you another case. This was the 65-year male patient who was non-diabetic, hypertensive, came with a chest pain, diagnosed to have an acute inferior polyp. So what will we have to do? They have loaded the patient with the dual antiplatelet as we do before procedure. Patient went for the procedure. They found that patient has a LV function is 45%. Coronary angiography was done. That suggestive of critical RCA, and another reason in LAD. Patient was done angioplasty. After 20 years, patient bleeded massively GI. What to do? One side, if you don't give, then it will thrombose. Ischemia will happen. If you give, patient will probably die of the bleeding. This thing we have to choose in such case. Of course, at that moment you have to stop the individual platelet. It's not there. So how to manage? We have to rest you all the normal. You have to put the IV proton pump and you perform the GI endoscopy. Right? GI endoscopy has shown that this is not massive ulcer. Malarial was there, and this patient HB dropped from 12 to 8. So we managed with the blood transfusion. After 24 hours, the patient was not bleeding by anesthesia. So what to do? We have to give. Patient had just less than 24 hours at the PCI. So we started ticagrelor, which is the P2Y12 agonist, and it was continued for 7 days. At least we have to give one because the ulcerative property of this is less than aspirin is aspirin. So before discharge, patient was restarted on aspirin, and which he tolerated well. And after 3 weeks, because another vessel's LED was blocked, it was performed. and everything went well. So this is the gas flow. I am not going on this, probably you will know. What do guidelines say in such situation? Again, nothing much. Nothing much. There was one article published on 2 years ago. In that, author tried to review the more than 81,000 articles regarding the double anticoagulant after PCI who developed the bleeding. Out of that, only 4 articles was found who gave some sort of guideline. That was one, the Danish Society one, ACG one, ICG one, and the British Society of Gastroenterologists. That is also, if you see, there is a way thing is there. Yes, you can stop, you can start after 24 hours depending on your decision, patient condition. There is no clear-cut guideline. So which can guide us clearly. If you are doing your right, I am doing I'm right. So, but what is any, what should we do? Basically, this is sometimes we help with the gastroscopy, endoscopy guided. As you all know, that's a forest classification, basically is a endoscopy based classification. So, if classification is in class A, 1A, 1B, 2A, I will tell you what is 1A, and 3B, then it's considered as the major bleed. In that case, you should stop this, and you start the aspirin after 3 days if patient was in aspirin. And second look of the endoscopy should be done, and then you decide with the consultation of your cardiologist when second DPT should be resumed. Because patient has just had a PCI. We can't dare to stop this unless there is no way out. But if it's a low risk forest classification, which is 2C and 3, then no need to stop. You can continue. Patient is a single antiplatelet, you can continue. If patient is in a dual antiplatelet, you can continue. This is the, no need to stop. So this is the forest. I took help from somewhere book. So that's basically class 1, 2, it is endoscopy, depending upon how significant bleeding inside the GI tract. Right, basically upper GI. So this is the classification of the forest based on the endoscopy. It must be coming your mind now. So if this is the situation, should before starting antiplatelet agent, all patients should go for bleeding risk assessment? Answer is yes. We don't know how much we are doing in clinical practice, how much cardiologist is doing, I am not sure. I am not cardiologist, but should? Yes, certainly. Why it? How it will help us to, if we do the bleeding risk? 1, this assessment help you to decide the duration of EPA, double antiplatelet. Second thing, potentially shortening is duration, and if possible, we can use the alternative antiplatelet agent to balance bleeding risk with the prevention of thrombotic. So this is it. Next, what should be assessed? What are the factors to be assessed to assess the bleeding risk? One is the patient age-related factors. In that, we have to consider the age, renal function, history of bleeding, and if patient is having any other comorbidity, procedural factors. That type of study is very. If his bare metal is used, duration is different. If drug relating is used, different. So this and the bleeding risk that we discussed, we should use the scoring system, whatever I mean, like precise Paris DPT, there is a mini scoring system that will help you. This is precise, this, I'm not going on that. One more thing I guess is coming to mind, that if is in such situation, should we go for brain scan or endoscopy in every patient before starting? Answer is no. It's not recommended. Routine brain scan is not recommended to do in assumption that patient will bleed. So only thing, if there is a strong neurological history, strong history of bleeding or any significant impact, then you may consider for that, otherwise it is not required. Similarly, endoscopy is not considered unless it is indicated strongly. Now for surgical side. So now third case is there. If patient underwent surgery, this is two bleeding case. Now if patient need urgent surgery, what we do? Is any way or just to stop medication? Let's see this case. This is 60-year male smoker with hypertension. I have time. So hypertension and dyslipidemia presented with the anterior but during admission, patient gave history that 3 months earlier he had epigastric pain, which he ignored. He has not given attention on that. As soon as STP was diagnosed, patient was loaded by the double antiplatelet. Patient went into the PCI and everything went well. And patient was sent home on the dual antiplatelet agent and supportive secondary to surgery. 3 months later, he came with a fever and epigastric pain. The ultrasound was done. It found that there is a mass in the head of the pancreas, which was confirmed after CT scan that yes, patient is having mass in the head and body of pancreas, and in clinical examination found that patient had the supraclavicular lymph node. So what to do? Should we wait or should we go for surgery? If we go for surgery, how to go for surgery? So as I will discuss guideline, aspirin was continue in this patient, but another P2Y12 antiplatelet has been stopped, right? So third day surgeon decides no, we have to go for at least to remove this supraclavicular gland and see. So what to do? We should give any bridging therapy. Normal anticoagulation, we do the bridging therapy with a low molecular or heparin, but here, is this advisable? No, we have to use antiplatelet as a bridging agent. So what? We have option. One, Dr. Derek was telling to give the IV corrector, but that's if availability is there, we don't have everywhere this. And even P2, this I'm going to, this is glycoprotein to be 3K is also availability, Mauritius is a problem. So, it was decided, as you have to low molecular, you have to stop 12 to 24 hours before surgery. And they decided to give the IV glycoprotein inhibitor to act as the short-acting antiplatelet agent. So to save the heart and go for the surgery. In such case, they have given the 2 hours post-intervention. When they have done the excision, we have given this loading dose followed by this maintenance dose. This is short acting, we give the short dose. The same day, ticagrelor, which is P2Y12 agonist, was administered with a loading dose of 180 followed by 90 milligrams. 2 hours after the pain was stopped. So we covered the antiplatelet for whole duration. Now, On the 18th day, while patient was asymptomatic, adenocarcinoma of pancreas was confirmed. So now question is, it was advised for survival of this patient, he should go for the surgery. Otherwise, he will not die by cardiac, he will die by the pancreatic. So they decided, surgeon decided, no, we have to perform surgery. The surgery was performed on the 25th days. And as usual, patient has recently PCI aspirin was continued. And another P2Y2 agonist was replaced by this glycoprotein 1 with a loading dose followed by the maintenance dose. And then when it is stopped, we have to continue with that. So this patient after that, patient did well. I'm not going to details when to stop and when to do that, because in the previous case I have already discussed that. So this is that. So what literature and guidelines say? See, around 15 to 20% who are receiving anticoagulants will require the surgery, and 10 to 15% patient with a coronary stent will require surgery with 2 years of it. It's a big number. So we should know how to manage the case to protect the heart and do the other disease we treat. So there are three scenarios we can face. One, patient needs urgent surgery. There is no way. You have to take the patient. Go for that without stopping. Or patient needs semi or urgent surgery. Then in that case, you have to decide case by case. Then again, you have to assess the risk and promote risk. And accordingly, you stop, but you can't stop all. Unless there is a very, very high risk of that. And if it is elective, please don't stop anything. Wait for the duration. So what American College of Surgeons recommend? If it is not urgent, wait for 9 months surgery. Don't go for that. In patients with coronary stent, most of which patients are on dual anticoagulation. So, if preoperative period should be delayed, 6 weeks if patient is present for with a bare metal stent, and it should be 6 months if patient is in a drug-eluting stent. If I told you if surgery cannot postpone, please continue both the antiplatelet and take risk and manage as per the need of that outcome. Similarly, as I discussed you that aspirin should be continued throughout the perioperative period, and this you know how to stop this. Now, just 2 minutes I will take for this last question. Now, throughout I am discussing double antiplatelet to be given risk. Out of 2 double antiplatelet, aspirin is one component. Another you vary whatever you are giving, clopidogrel. But suppose the patient is allergic with aspirin, then what to do? This patient was 60-old-year male patient, known diabetic 2, has systemic hypertension and dyslipidemia, presented with a chronic angina, class 3, which was progressive to, from last 1 week, is a progressive myocardial ischemia is going. And when he was investigated, found that he has this LED long segment LED is blocked. So they offer, because he has previous surgery, CABG and other treatment which he refused. So they decided to, patient, he was not willing for the same, for the proceeding for the PCI to LED. So patient gave history that he has a gastric problem with aspirin, which is very common, it's not an uncommon thing. He denied prior episode of angioedema and anaphylaxis-like situation. So he was loaded with the aspirin and another P2Y2 ticagrelor. After 4 hours of the procedure, patients developed ischemia and angioedema. So obviously there will be confusion whether contrast has caused or aspirin has caused. There is two possibilities will come to our mind. So what should do? Should he receive the antiplatelet treatment? If yes, which one? What about the antithrombotic treatment for this patient's management history? How it was managed? First, you have to see whether it is an angioedema or it's a local coincident. Yes, it was fortunately patient responded well with the corticosteroid, was not required adrenaline or anything. So his allergic episode was subsided, and that this patient was treated with the ticagrelor and silostazol. Silostazol is there. So this is the what do the guidelines say? In such case, what to do? Only we should go for one antiplatelet. We should add the anticoagulation therapy, or we have to desensitize the test. So we should give the best trial to desensitize the aspirin. The first in this case to find what kind of edema was there. Is it quick or anaphylaxis? If the aspirin allergy is confirmed, of course for that time you have to continue the another antiplatelet P2Y12, briefly ticagrelor, which is potent, and may give the short course of parenteral anticoagulation. In stable patients who are about to be planned for the PCI, the procedure should be postponed and first try the aspirin desensitization. And if patient is treated with conservatively, if he requires CABG, a P2Y2 inhibitor should be administered instead of, because patient is going CABG, so he can wait for that. But what to do if patient is stable, required urgent PCI? So in such case, you have to give the P2Y2 inhibitor plus IV, the glycoprotein 2B, 3B inhibitor where is available, WP is the in all place, and let the patient to settle. And do the aspirin desensitization when patient becomes stable after all this age. There was one recent trial was done that was published in 2 years ago. That was absence of adverse thrombotic and bleeding events observed. Suggests that ticagrelor monotherapy could be the viable option for patients who cannot tolerate aspirin. But then you have to assess this. The last thing, I for the medical students that how to do desensitization of aspirin before I closing that. So basically, it's 2 days protocol. You start the aspirin desensitization with the 1/4 of the tablet, and then after 3 hours, you give the 3/4 of this is 81 milligrams of tablet because we have different strength of that. And if there is no reaction, then second day you can use 1.4 tablets. After 3 hours, 2 tablets, and then 324, which is the loading dose of that. So, hope this was the case oriented. Thank you very much.
Yeah. Thank you very much, Dr. J.K. Mishra. It was a very lucid presentation, absolutely student-oriented. You have shown them how to face challenges and overcome them with ease. That is very important because it's a predicament whether or not to continue once you have the side effects. Okay, and with your permission, now we can open it for question answer if you don't mind. Thank you. Now the session is open for question answer, and we prefer if the students come forward and ask for questions. And kindly use mic and be related to the topic. Ask question, no comments, no suggestions, just questions initially. Thank you.
then you have very unique presentation. And on this island, this is what happened, what difficult, not as in the book what we are reading, that different types of challenges comes and how you learn. That means that not everything is in guideline, then you have to decide this thing regarding SP and 12 antiplatelets, and we are using it as a guideline we are using. Previously, what is I attended one cardiology society of India, specific international conference. There, most of the people, you mentioned here that aspirin and that's allergy, that's same thing happening in aspirin resistance. Then the aspirin resistance is, I don't know that is exaggerated or not, 33% of the cases of the aspirin are resistant. That's why people are taking these medicines, the aspirin, and we still on the top of the aspirin are being taken up, and that's MI. That's why sometimes this is happening, but you in the on this side you have to do that. So many information, not only the insulin, all the faculty of the we state your scenario, what happened, and in the clinical setup, and different type of population are coming, and different that's how you tackle. This is a good lesson for all, not only for the again, I congratulate you for giving them all the debate what you have done in your practical last quarter century here in Mauritius. Thank you. Thank you,
Actually, why we need double antiplatelet therapy? Previously, we were using one. That's happened. The issue is it's not blocking both this. There is a several reasons. Even B2Y2 has very prone to get it. Clopidogrel has very prone to get this resistant issue. There is so many different this is there. So that's the reason, yes, we are giving that to block platelet as much as possible. Thank you, sir. Thank you.
Could you tell me, have you seen the case of aspirin-induced asthma as a complication? Asthma.
See, it's different mechanism of aspirin. Aspirin has different mechanism. Aspirin can cause the different reason of this. IgM mediators is different. There is asthma is a different mechanism of aspirin induced. Aspirin has different sensitivity issue and different mechanism. Not one. I have seen it. I have seen this. In fact, it's happening.
Thank you. If there are no questions, now you can give suggestion also if you so desire. Otherwise, we'll close the session. Thanks once again, and kindly appreciate his efforts.
Thank you, Dr. Mishra. It was very insightful and engrossing talk. Now we'll proceed with the certification. I would like to ask the chairs, Dr. Sushil, Dawka, and Dr. Lavania, to present the certificate to Dr. Mishra. I would like to ask Dr. Mishra to please come on stage.
I'd like to invite on stage Dr. ABC to give the certificate. Dr. Dawka and Dr. Lavania.
We shall now proceed to the poster session where our enthusiastic colleagues will be showcasing their research and innovative ideas. During this time, all the delegates and faculty members are invited to take the gallery walk through the displays. While the students present their work, the session will be held in a theater wing. All the 4 sessions will be starting together. This will be followed by a lunch break at 12:40, and we shall resume the 3rd session at 1:15. Before that, I'd like to request everyone to please hold on to the feedback form. We will soon collect it. We look forward to seeing you all there. Thank you so much. The 3rd session will start at 1 o'clock. Thank you. Students, the lunch break would be at the biochemistry lecture hall, and for the faculty and delegates will be at the main room.